It will very share the YouTube link. Take it. Pure. So can I go ahead?
Yes, sir.
Dear Pure Urology viewers, good evening, one and all. Today topic is not exactly surgical technique topic, but we are going towards a lot of chemotherapy drugs in urology. Till now, we are having adjuvant chemotherapy in carcinoma bladder and much of the chemotherapy in testicular cancer. Now, almost every cancer in genitourinary system, one way or the another way, the chemotherapeutic drugs are used. So I thought for the PGs and junior consultants for exam going for and even for the practicing consultants, this is important because you will be knowing common complications, when to refer the case and when to utilize the drugs appropriately. That was the intention, though it is not a surgical technique. The today's speaker is Dr. Srinath Bharadwaj, MD, DM Oncology. He did MD from Usmania Medical College, which is prestigious college in Andhra Pradesh and Telangana. He did DM from GCRI, that is BJ Medical College, Gujarat University, Ahmedabad. Currently working as the consultant medical oncologist in Apollo Jubilee Hills this thing. And he published various international and national journals. And he has also received many awards. With this introduction, I thank Dr. Srinath Bharadwaj for accepting this invitation. Over to you, Srinath, please.
Firstly, I would like to thank you, sir, for this opportunity. And there's one disclaimer before I start my screen. The guidelines and the chemotherapies which are already established, I'm not going through all of them because of the lack of time. I think topic by topic, if we want, we can have another discussion. But the newer therapies and the neoadjuvant therapy and all, which have been recent updates in the past 5 years, is what will be the core of this presentation.
Yeah.
With that, I'll like to start sharing my screen.
Okay. Yes.
So here we dwell upon systemic therapies in uro-oncology, which are the recent updates, and organ by organ, we can do it in different sessions because it becomes very exhaustive if we do it together, and we should be also able to grasp something out of what we are discussing and retain it. So I would start initially with prostate cancer and androgen deprivation therapy. There are newer things which have been coming up for suppression of the androgen or the testosterone recently. So I would just want to start with this topic. So androgen deprivation therapy started with estrogens historically, and estrogen inhibit the release of gonadotropin releasing hormone from the hypothalamus and thus suppressing the pituitary LH and in turn testicular production of testosterone. So diethyl stilbestrol was the first used estrogen in urology to deal with prostate cancer. Coming to GnRH analogs. So this discussion, why I would like to bring over is it's always a discussion which is active, whether to use GnRH analogs or GnRH antagonists. So here I would like to dwell upon these particular features, and the analogs specifically are higher, 100% higher molecules with higher 100% higher affinity to GnRH receptor on the pituitary gland than the natural hormone. So they go and bind with it, and receptor downregulation starts in about a week. And there is something called as a flare phenomenon, where initially there will be more production of testosterone. So this is one caveat of using a GnRH analog. And castrate levels are achieved within 3 to 4 weeks of starting the treatment. And there is decrease in testosterone production may or may not be reversible, and that depends on the duration of the therapy and the age of the patient. So the drugs, leuprolide depot injection has been most commonly used in various sectors of practice. So the doses can be given monthly, 7.5 milligram, 22.5 milligram every 3 months, 30 milligram every 4 months, 45 milligram every 6 months. Now there is a subcutaneous formulation also, which is given 1 milligram subcutaneous daily. So gocirelin is the other one, which comes in the name of Zoladex, and it also can be given as a 28-day implant, the 3.6 milligram subcutaneous, and a 12-week implant, which is 10.8 milligram subcutaneous. Triptorelin, not very common in my practice at least. I'm not sure if other doctors use it, but this is the schedule for triptorelin. These are the buserelin, also not very common in today's practice, but yeah, so these are the dosing schedules for buserelin. And the drug warning is whenever we use buserelin, we definitely have to use an androgen blocker like bicalutamide to prevent the flare. So the target is, as we all know, it's medical castration, and that is the values of testosterone below 0.7 nanomole per liter or 50 nanogram per deciliter is what is our target. And it is pertinent to achieve castrate levels in the first year of treatment. That is the target of treating stage 4 or prostate cancer with hormone therapy, because there is data now. If we don't achieve a castrate level in the first year of treatment, then those patients will do worse. And medical castration with GnRH analogs has good enough data, which is equivalent to surgical orchidectomy in overall survival, progression-free survival related outcomes, and also time to treatment failure. Coming to antagonists. So there are two molecules here. One is an injection, which is degarelix, and other is a tablet, oral tablet called relugolix, which has come up very recently. The phase 3 trial, which compared degarelix 240 loading dose followed by 80 milligram or 160 milligram monthly with 7.5 milligram monthly leuprolide. The biggest advantage with GnRH antagonists, especially degarelix, is it suppresses testosterone levels within 3 days in 96% of the patients and lowers mortality rates, and the incidence of cardiovascular problems is much, much less compared to GnRH analogs. So this makes it an obvious choice in a patient, especially who presents with a painful bone mets and severe urinary tract obstructive symptoms, where we cannot afford a flare phenomenon, where we give a GnRH analog and the symptoms slightly increase before decreasing. That's not possible when the patient comes with these symptoms. So degarelix would be the go-to drug in such scenarios. So other molecule which is orally highly selective GnRH antagonist is relugolix, and relugolix 120 milligram once daily was compared to leuprolide, and again the rapid suppression happened in around day 4, and the likelihood of maintaining castrate levels through several weeks, like 30 weeks, around roughly 29 to 36 weeks, has been significantly higher with relugolix compared to leuprolide in this study. And the mean testosterone recovery, in case there is a cardiac decompensation and we need to stop the therapy, the mean testosterone recovery in case of that stoppage was also quicker with relugolix. And compared to analogs, with the antagonists, the cardiovascular side effects are much, much less. And this has a very significant role in our practice, because we see a lot of metabolic syndrome, cardiac disease in our Indian population, especially the age group what we are talking about, prostate cancer. The side effects of ADT, we have to keep in mind the loss of libido, erectile dysfunction, decreased penile and testicular size, subjecting the patient to osteoporosis. So we all have that habit of prescribing bisphosphonates along with androgen deprivation therapy, and they tend to have hot flashes. The metabolic syndrome risk increases with weight gain, and increased risk of cardiovascular disease, thromboembolic events, and including emotional and cognitive disturbances and fatigue. So now the updates have the previous, I think the regimen, age-old regimen used to be combination of ADT, whatever drug it is. So in combination with bicalutamide used to be the most common total androgen blockade. But now we have several newer drugs, and combining ADT with these therapies, we are using the definition of high risk or high volume or low risk or low volume based on the Stampede and Latitude trials. And high risk and high volume disease in a metastatic prostate is described as somebody presenting with visceral metastasis, more than or equal to 4 bone metastasis, and at least one outside the axial skeleton, Gleason score more than or equal to 8, and of course, metastatic disease on presentation. So docetaxel has a definite role in this particular context. In high volume and high risk disease, combination with ADT increase the overall survival from 47 months to 58 months in the intent to treat population, and the delta was even more in the high risk. I mean, this was a combination of all, but the specific benefit was seen in high risk, high volume cases. And of course, it didn't show any benefit in the low risk, low volume cases. And meta-analysis of the charted and other trials also confirm these findings. The dose is 75 to 100 milligram per meter square. We use 75 milligram per meter square in majority of the Indian patients because they can't tolerate dose much more than that. And it is given through a non-DEHP tubing because polyvinyl fluoride, the plastic which is there in the IV fluid sets and the plastic bottles, they react with taxanes, whether it is docetaxel or paclitaxel. So we tend to avoid polyvinyl fluoride bottles, and we have PVC-free bottles, which we have been using for this. Or the other option is to use a glass bottle. So the mechanism of action of docetaxel is again a microtubule inhibitor, and it has a binding site which is separate from other microtubule inhibitors on the beta subunit of the tubulin, and it binds to beta subunit of tubulin and suppresses the treadmilling and dynamic instability, thereby altering the dissociation rate constants, which is in the anaphase when the tubules split. So these drugs act during that period and inhibit that split, and hence stopping the mitosis meiosis program, especially in the G2M phase, cell cycle arrest, and they cause cell death. By this action, they also stall the ligand dependent cellular trafficking of the androgen receptor, leading to its sequestration in the cytosol. And the androgen receptor is not carried to the nucleus so that it is translated into producing more PSA and more proliferative signals to the prostate cancer. The side effects of docetaxel, everybody has neutropenia for sure, 100% I can say, at least because we see in every case, maybe febrile, maybe afebrile. Hypersensitivity reactions are very common with taxanes. We have to keep an eye on them and attend to the patient immediately. Fluid retention and weight gain incidence. This is very important because again, we're dealing with patients most probably having a cardiac condition. We don't want any fluid retention. So steroid pre-medication is what we have to give. Of course, it may worsen the diabetes temporarily, but we don't have an option when it comes to fluid retention. And palmar plantar erythrodysesthesia and onychodystrophy will be blackening of the nail beds and weakening of the nails. This is again a universal side effect. Hardly any people who have really gone past docetaxel without having this side effect. Neuropathy and neuromuscular effects are less compared to paclitaxel. Stomatitis is more compared to paclitaxel. All the taxanes have an impact on the peripheral neuropathy because again, because of their primarily action on the microtubules, which form the basis for again neuronal transmission. So this kind of reactions we can see. One lady which I've used docetaxel for breast cancer, she had this kind of a reaction on her entire body, and of course, she didn't take the further cycles. So cabazitaxel is the congener of docetaxel. It's a semi-synthetic derivative of the natural taxoid 10-deacetyl becatin, and cabazitaxel is a poor substrate for the P-glycoprotein efflux pump. So it is less thrown out of the cell compared to docetaxel, if I have to put it in common terminology, and hence it is also approved by FDA post-progression on docetaxel. So whenever we see people progressing on docetaxel, the obvious next drug of choice would be cabazitaxel. Again, the dosing is around 20 milligram per meter square, again via a non-PVC bottle and an IV codon set. So Cabazitaxel has a biological and clinical characteristics that are distinct from docetaxel. Include the penetration through blood-brain barrier is much better compared to docetaxel, and that is good in a way because at that end stage we might see patients who have developed brain metastasis, and improved cytostatic and cytotoxic response that is independent of the androgen receptor signaling in castrate-resistant prostate cancer, in which setting we use it most. And inducement of molecular actions that are distinct from docetaxel, and it kind of creates a different genetic milieu in the tumor, which helps in killing the tumor much effectively despite docetaxel resistance. So tumors that developed castration resistance by RB loss show good sensitivity over docetaxel. Again, cabazitaxel is associated with more grade 3 or grade 4 neutropenia, and side effects are reported in more than 20% of the patients, include myelosuppression, diarrhea, nausea, vomiting, constipation, abdominal pain, and asthenia. Some minor side effects can be there, but we'll have to tackle it. So just to have a look, we all know that the androgen sits on the androgen receptor, and then androgen receptor is carried with the androgen, which is testosterone or dihydrotestosterone, is carried from the membrane through the cytosol through heat shock proteins into the nucleus, where it goes into the nucleus, and then it starts transcription and translation, and hence producing signals for PSA and also for cancer proliferation. So the combination of novel hormonal agents with ADT and chemo. Now, ADT bicalutamide, step 2, ADT and docetaxel in high volume, high risk disease after Stampede and Latitude. Now, the third or the latest one, which has been in the prime front in the past 2-3 years, has been combination of the newer hormonal agents with the combination of ADT and docetaxel. So the Arasens trial, which has been published very recently, as in 2 years back, where ADT combination with docetaxel and darolutamide improved overall survival in both high risk, high volume and low risk, low volume groups. The 48-month, that is the 4-year overall survival, was 63% compared to 50% only with ADT and docetaxel. There were consistent benefits from darolutamide in all the secondary endpoints, including time to develop castration-resistant prostate cancer, time to pain progression, symptomatic skeletal event-free survival time, and that is the time to first symptomatic skeletal mets. The benefit extended to all pre-specified groups, including people with visceral metastasis like liver mets did well with this combination. The dose of darolutamide is around 600 milligram twice daily, and the biggest side effect what they have seen in the trial is seizures, but occurred only in 0.6% of the population, and that to around a year of starting darolutamide. Neutropenia, majorly grade 1-2, some transaminitis, hyperbilirubinemia, asthenia, fatigue were seen. The United States prescribing information recommends darolutamide dose to be reduced or start with a lesser dose when already there is a concomitant hepato or renal toxicity. And of course, we have to warn all the drivers, especially taking these drugs, including enzalutamide, to avoid driving because there will be risk of seizures, whatever percentage it may be. But if that person develops it, it's going to be fatal for all the people who have been following him. Mechanism of action, all the newer hormonal agents are competitive androgen inhibitors, prevent androgen receptor translocation and androgen-mediated transcription, leading to apoptotic cell death. They cross blood-brain barriers in very low levels. That has been a concern because people with brain mets, we have to irradiate them. Then only the blood-brain barrier is going to breach, and these are going to have intracranial activity. So again, they are also indicated, darolutamide is specifically also indicated in M0 castrate-sensitive prostate cancer. That is, people having a biochemical recurrence after a radical prostatectomy, darolutamide can be the drug of choice. The role of darolutamide in castrate-resistant prostate cancer is not well established yet. Similar trial is PEACE-1 trial, which combined androgen deprivation therapy with docetaxel and abiraterone. Again, we had similar results, but the overall survival data was not very strong compared to darolutamide. So in the United States, the recent practice has been always combine ADT, docetaxel, darolutamide as the first option compared to abiraterone, because the trial data was pretty stronger than the abiraterone trial. But in India, the scenario is a bit different. Darolutamide costs us around 1.1 lakh per month. So we kind of tend to combine docetaxel and abiraterone in majority of the patients when they present with high risk and high volume. So again, the darolutamide trial, as we discussed, showed benefit in low risk, low volume also. But in the pre-planned subgroup analysis, the abiraterone trial showed only survival benefit limited to the high metastatic burden cases. So the guidelines also are updated, and high volume, high risk disease, ADT with preferred regimens, combination of abiraterone and darolutamide along with ADT docetaxel has been updated in the recent NCCN guidelines also 2025. I'm sorry, I just put up a video, but that's not playing right now. That is just to tell the mechanism of action of abiraterone, where it prevents the formation of dihydrotestosterone from pregnenolone, and hence abiraterone will kind of push the androgen biosynthesis in a direction where the mineral corticoids are produced in excess. So that leads to the common side effects of abiraterone, which are hypokalemia and hypertension. So to prevent that, we use a combination of 5 milligrams of prednisolone daily to suppress that mineralocorticoid excess and kind of prevent hypertension and hypokalemia from developing in every patient. And they did also combine other agents along with darolutamide and abiraterone. They combined enzalutamide also along with ADT and docetaxel, but the trial was a failure, and no benefit was seen with combination of enzalutamide. And instead, actually, the enzalutamide induced side effects were much more. Apalutamide was not tried in the setting in any phase 3 trial till now. So ADT in combination with one of the hormone agents like abiraterone or apalutamide or enzalutamide has consistent data in low volume, low risk disease, and there is some data of radiating the primary prostate along with ADT and abiraterone in low risk, low volume disease. So the newer androgen blockers, as we see, the highest in this, I would like to just draw your attention towards the enzalutamide fourth row, where the blood-brain barrier penetration of enzalutamide is pretty high. So that would be my drug of choice when there are active brain mets. And but again, we are also kind of subjecting the patient to a risk of seizures, which we have to be careful with. And apalutamide, the major side effect has been rash, seizures, and hypothyroidism. So these drugs, as simple as they appear to be used, but they do have some very strong side effects, which we have to keep in mind before using them. So the recent genetic update of prostate cancer is that of the BRCA and HRR testing, which we are consistently testing now. Not in all the early stages, but definitely in stage 4 and castrate-resistant prostate cancers. Patient with family history, ACNR variant, or intraductal histology. Positive cases can be treated with PARP inhibitors. There are drugs which I mentioned, olaparib, rucaparib, and talazoparib. They have been approved by the US FDA. Now there are multiple trials which have seen combination of enzalutamide or abiraterone along with olaparib, and but they're all currently being they've initially been tested in the second line after the initial ADT docetaxel. Second line BRCA positive, we used to go for olaparib. Now there is slowly data coming up in the first line also, where olaparib and abiraterone showed good radiological progression-free survival benefit, and it is a FDA-approved regimen now with ADT, abiraterone, and olaparib that can be used according to Propel data. So the next big thing I think in urological oncology today, apart from what chemotherapies we know, is immunotherapy. So precisely again, this is a video which currently is not playing, but what is immunotherapy? The funniest question raised by many patients when I try to counsel them about immunotherapy is it like some Zincovit or is it like some immune booster? I said, no, it's not an immune booster. Uh, it is a pathway of attacking the cancer. So the cancer cells, one of the major mechanism by which they progress in the body is by evading the immune surveillance. That is, cancer cell, which is a foreign cell, has to be recognized by the immune system as foreign. But they wear a mask called PDL1, which we see in this image, and hence they go and attach with the PD1 receptor on the T cells, and it kind of gives the cancer cells a local identity card. The immune T cells stop attacking it as long as the PD1 and PDL1 are combined. So what this immunotherapy does is either it goes and sits on PD1 or PDL1 and stops this interaction where the T cell is now kind of it realizes that this is foreign and the T cell comes and attacks this. So that's how immunotherapy was found, and I think the founders or the scientists who discovered that also got Nobel Prize for Medicine for discovering the mechanism of immune evading immune surveillance by the cancer cells. So there is another pathway called the CTLA4 pathway also, just like the PDL1 PD1 interaction. CTLA4 is one way of blocking the immune attack of T cells on the cancer. So we have a lot of PD1 inhibitors, of which I have the ones I've highlighted in pink are the ones which are specifically being used in urological cancers. In that also, the first PDL1 inhibitor, atezolizumab, hardly has any data. So we'll be much focusing on this discussion on the other four molecules, that is pembrolizumab, nivolumab, durvalumab, and avelumab. So pembrolizumab is the drug. I don't know if that is the right word to use, but it is being described by the pharma industry as a blockbuster drug, and it has got the highest number of approvals in cancer. It is the highest sold drug in the past 2 years in the world, actually, for oncology patients. So let us see how many indications does it have in urological cancers. So I would start with bladder cancer. Bladder cancer, let us divide it into non-muscle invasive, muscle invasive, and metastatic. Pembrolizumab has indication in all three. Non-muscle invasive, intermediate, or high risk patients who are basically recurrent non-muscle invasive bladder cancer, that is, they have progressed beyond intravesical BCG, but they are poor candidates for radical cystectomy or they reject radical cystectomy. Pembrolizumab had shown good results, as in 2 years of pembrolizumab injection can give us a better survival chance, even if we are not able to perform a radical cystectomy. That is the indication in NMIBC. Muscle invasive bladder cancer, patient receiving platinum-based chemotherapy as neoadjuvant. Let us say they take cisplatin gemcitabine 4 cycles or a dose-dense MVAC 4 cycles as neoadjuvant, and they have undergone cystectomy, or they have undergone directly cystectomy and the post-op stage has come out as PT3, or the nodes have come positive, or there's some margin positivity. That is when adjuvant pembrolizumab, that is after cystectomy, it has improved the disease-free survival at 45 months from 30 versus 14 months without giving anything. So almost doubling of the disease-free survival by using pembrolizumab in the muscle invasive bladder cancer in the adjuvant setting after cystectomy, irrespective of whether we give neoadjuvant CT or not. So this is how we select adjuvant therapy in high-risk muscle invasive urothelial carcinoma of bladder. No prior, the first column, no prior neoadjuvant therapy, and directly the patient has undergone radical cystectomy, PT3 or PT4A, along with a node positive disease, and the patient meets all the eligibility for cisplatin, and they go ahead with gemcitabine, cisplatin, or dose and MVAC. The other scenario where neoadjuvant chemotherapy has been used and still there is a lot of persistent disease. In the sense, there is no pathological complete response. They go for adjuvant immunotherapy and that has shown survival benefit. Here, two agents can be used, pembrolizumab and nivolumab. I've discussed drug by drug immunotherapy. Nivolumab data also, I'm going to highlight it in the later slides. So coming to the stage 4. Now, NMIBC, I have told the indication. MIBC, I have told the indication. Metastatic. The first line for stage 4 urothelial cancers today is a combination of two drugs. One is enfortumab vedotin, that is an antibody drug conjugate, which I am going to highlight in the end of this presentation, and pembrolizumab, which we have discussed. So this trial has been published in NEJM, New England Journal of Medicine. So irrespective of now, I think with this trial in the medical oncology circles, the discussion about cisplatin eligibility, ineligibility has almost taken a backseat. Because irrespective of cisplatin or carboplatin eligibility, using any stage 4 urothelial cancer, using enfortumab vedotin and pembrolizumab combination has improved overall survival median 32 versus 16 months with platinum based chemotherapy. That is doubling of overall survival. So all the US guidelines have just changed that anybody who's eligible to take enfortumab vedotin and pembrolizumab, those are the drugs of choice now for stage 4 urothelial cancer, and we are not going for cisplatin based chemotherapy in the first line until unless there is a contraindication for either of them, whether enfortumab or pembrolizumab cannot be used. So you take anything, overall survival double, progression free survival 6 months to 13 months, overall response rate 68 versus 44, complete response rate 29% versus 13%. That is having a complete clean PET after 3 to 4 months of therapy. So you can see the curves. I put the curves beautifully separated, and even at 3 years, 60% remain progression free. It's a great data. So this has been the recent paradigm shift, I must say. Excuse me, in terms of first line therapy for urothelial cancer. The chemotherapy has gone totally out of the picture. That is what I wanted to highlight. So as again, pembrolizumab can also be used as a single agent in platinum ineligible patients and people who cannot gain access to enfortumab vedotin. We can use it as a single agent. Roughly 30% of the people respond, and it can hold on the disease for a certain period of time. After progression of platinum-based chemotherapy, also immunotherapy, it can be used in second line. It is approved. Compared to chemotherapy in second line, somebody takes carbogem or cisgem elsewhere and comes to us for a second line. Even in those patients, we can use it as a single agent instead of the chemotherapy. It has shown benefit of improved overall survival, 10 versus 7 months. It's not great, but definitely better than a single agent chemotherapy in the second line. Coming to the kidney cancer indications, again, I would like to divide pembrolizumab's kidney cancer indications into two. One is adjuvant, other is in stage 4. Adjuvant, these are the indications: intermediate risk or high risk tumors, PT2 with ISUP grade 4, PT3 of any grade, PT4 of any grade, or node positive tumors. In all these tumors, pembrolizumab for 1 year, that is total 17 cycles, improved the 30-month DFS by almost 10% and the 4-year overall survival by around 6 to 7%. So again, approved by US FDA, and all these patients have to be referred after a radical nephrectomy for adjuvant pembrolizumab now, because it is a documented standard of care with the overall survival benefit documented. Coming to stage 4 clear cell RCC, currently two pathways are being targeted in stage 4 RCC. We all know that there is no role of any conventional chemotherapy in stage 4 clear cell renal cell carcinoma. The VEGF pathway vascular endothelial growth factor pathway, in which we use all the sunitinib, pazopanib, lenvatinib, axitinib. All these molecules inhibit the VEGF pathway to control the tumor. The immune checkpoint pathway is the newer addition to this lot, and we are combining VEGF pathway with immune checkpoint pathway. Also, there is a dual immune checkpoint pathway where a PD-1 inhibitor and a CTLA-4 inhibitor combination is used. Which to choose and which is preferable? Whenever we need a quick response, let us say a renal cell carcinoma with a lung spread, having a lot of breathlessness. So we tend to combine a VEGF pathway inhibitor like axitinib and an immune checkpoint inhibitor like pembrolizumab. So that gives us a quicker response. But the caveat with this combination is it is going to plateau after, or the effect seems to be lost after 2 years. Combination of the dual immune checkpoint inhibitors, let us say nivolumab and ipilimumab. So that takes time to kind of get the response, but the response seems to be very sustainable, like the responses with interferon previously. So these are the two differences, and based on the clinical presentation of the patient, we tend to choose between either of them. Both are not wrong in a way. So the trial which combined axitinib and pembrolizumab actually was the game changer few years back, and it improved overall survival 63 versus for 54%, and the 4-year OS 49 versus 46%, or the 5-year OS 42 versus 37%. And of course, the longer PFS also compared to sunitinib, which was the previous standard of care. So I've used it. This regimen has been my go-to regimen since the past 3 years, and touch wood, none of my patients still recurred. I mean, the patients from 2 years, 3 years, stage 4, and none had a recurrence till now. I've stopped pembrolizumab after 2 years, and hopefully they're doing very fine for now. There is another trial which combined lenvatinib and pembrolizumab, and this seems to be, I mean, it's very wrong on our part to do a cross-trial comparison, but the lenvatinib pembrolizumab trial seem to have better results than axitinib pembrolizumab. Of course, the loss of response after 2 to 2.5 years was there, but technically speaking, numerically, the PFS, OS, and the ORR seem to be better than better in the lenvatinib pembro trial compared to axitinib pembro. But lenvatinib is a tough drug to handle, and a lot of stomatitis, a lot of hand-foot syndrome, excessive fatigue. So very difficult drug to handle, and the dose also, many people find it very difficult to tolerate the lowest dose also. So axipembro still, I think, in my opinion, remains one of the very good regimens. Coming to our second agent, that is nivolumab. Nivolumab is the second PD-1 inhibitor after pembrolizumab. Again, I'll start with bladder cancer here. Nivolumab doesn't have any indication in non-muscle invasive bladder cancer. In muscle invasive bladder cancer, we have seen, so we can do it as an adjuvant therapy after radical cystectomy if there is no pathological CR to platinum-based chemotherapy. Or again, the same indications after upfront surgery, PT3 or PT4A, or nodal positive disease or positive surgical margins who are ineligible for cisplatin-based adjuvant chemotherapy. Nivolumab can be used as a single agent. So again, the trial data at 20 months, nivolumab improved disease-free survival from 21 to 11 months. There it was 14 months to 30 months. Here it is 11 months to 21 months. Again, distant metastasis-free survival has also quite significantly improved. Yeah. So coming to stage 4, muscle invasive bladder cancer, we've seen the indications. Stage 4 bladder cancer, nivolumab combined with cisplatin gemcitabine is one of the appropriate options now. As I told, the standard of care is enfortumab vedotin and pembrolizumab. Only people who cannot tolerate or don't have access to both of those agents will be planned the other options. There are two options. One is nivolumab combination with cisplatin gemcitabine, and there was documentation of improved OS, which is statistically significant, but clinically very less, I must say. It's only 3-month overall survival. but definitely statistically significant. So they got a US FDA approval. And the combination therapy also increased the duration of complete response and improve the objective and complete response rates. So again, now this is the regimen which I've been talking to previously, the combination of nivolumab and ipilimumab. It's a combination of PD-1 and a CTLA-4 immunotherapies. The dose of nivolumab is around 3 milligram per kg and ipilimumab is 1 milligram per kg given every 3 weeks for 4 doses. And then ipilimumab is stopped and only single agent nivolumab is continued. So as I told, the improvement in a 7.5 year overall survival is what we are seeing in this combination. So the duration of response is also roughly 7.5 year duration of response was 48% versus 19% in the sunitinib. So the dual immunotherapy, the responders are a bit less compared to the combination of VEGF and immuno. But people who respond tend to do very, very well. We are seeing the 7.5 year response rates in a stage 4 clear cell renal cancer. And one more thing, one more point I would like to make here is the non-clear cell papillary cell carcinoma has been very less responsive to the combination of axitinib and pembrolizumab and the VEGF and immuno. But it has the best data in the combination nivolumab and immunotherapy arm. Nivo-IP combination is one of the go-to choices for a papillary RCC currently that has the best response rates. Another indication is the combination with the, again, VEGF inhibitor cabozantinib. Again, it has a OS benefit when combined with cabozantinib, nivolumab. So it's one combination, again, used in stage 4 RCC as first line. So the next topic would be about durvalumab. Now, I'm not sure. I rather post the talk. The discussion can happen. How many of you practice neoadjuvant chemotherapy before going for a radical cystectomy? And now the addition is the immunotherapy in combination with cisplatin gemcitabine before radical cystectomy for 4 cycles, and again giving adjuvant immunotherapy irrespective of the pathological complete response or pathological partial response for 8 cycles, that is 8 months. That has become the standard of care now after this trial, Niagara trial, got published last year in the New England Journal of Medicine. So at the median follow-up of 42 months, the combination of durvalumab with cisplatin gemcitabine improved the event-free survival. The 2 year event-free survival was 68 versus 60%. Again, overall survival was also improved by around 7%, which is quite good and not to be seen in the previous trials of this sort. So this makes it the current standard of care for neoadjuvant CT in MIBC in cisplatin eligible population. To be precise, we are not only giving DDMVAC or cisgem right now as NACT, and the ideal way to go is to combine it with immunotherapy durvalumab. The last immuno-oncology agent which I would like to discuss today is avelumab. The only indication it has in bladder cancer is in stage 4, and that too in a switch maintenance. What is a switch maintenance? We don't use avelumab in combination with cisgem, but we give 4 to 6 cycles of DDMVAC or cisgem for a stage 4 patient. And after he achieves a partial response or a complete response on PET, we give immunotherapy maintenance till progression as a single agent. And it has shown an overall survival benefit of 3-year OS 36 versus 30% and a median OS of 24 versus 15 months. So the overall survival by doing so improved from 1.5 year to 2 years. And the other indication for the drug avelumab is axitinib and avelumab combination in the first line in clear cell RCC. But the OS is not very strong data, so this has taken a backseat compared to the other immuno-oncology molecules, that is axitinib pembrolizumab, lenvatinib pembrolizumab, and cabozantinib nivolumab. Those are the 3 options which we have. Compared to this is the 4th option, but the OS data was not very strong. Maybe the population they selected was not really, or they chose a high burden disease, probably. So what are the common side effects of these newer molecule called immunotherapy. It doesn't have side effects similar to chemotherapy, like the neutropenia, like the mucositis, like all the color changes, skin changes. But what is the basis for the side effect of this is we are stimulating the immune system, we are activating the T cells in a way. So all the side effects of immunotherapy are due to hyperstimulation of the immune system. And it can involve any organ virtually, because any organ can develop an autoimmune attack. But the common organs which we see in daily clinical practice is dermatological, skin rashes, ranging starting from skin rashes to Steven Johnson syndrome, diarrhea or colitis, autoimmune colitis. We see a lot of autoimmune hepatitis, pneumonitis, endocrinopathies. It can be it can be hypoadrenalism, it can be hypopituitarism. Most common is hypothyroidism. It can be thyrotoxicosis also. Autoimmune myocarditis have also been seen where patient presents failure. So how do we manage it? We kind of grade the toxicity according to CTCAE, and grade 1, grade 2, grade 3, grade 4, grade 5. Grade 5 is death. So grade 1 and grade 2, we tend to hold immunotherapy. I only put one example for this. I don't want to put every side effect and explain on that. Grade 1, grade 2, we tend to stop immunotherapy temporarily and start symptomatic treatment. It can be steroid also. So one more thing is, one big difficulty for us as medical oncologists is we can't use steroid pre-medication for vomiting control when we use immunotherapy, because obviously they both have different mechanisms of action, and we can't use steroids as a breakthrough or even as a prophylaxis for nausea and vomiting of chemotherapy when we combine. So again, because now when they develop an autoimmune side effect, whether it is skin, hepatitis, or pneumonitis, we tend to start steroids and stop chemotherapy, stop immunotherapy, so that the symptoms come under control. Somebody develops a grade 3 or grade 4, immunotherapy has to stop, and it's a complete no-no from there. We tend to choose other agents to try to treat that patient. Antibody drug conjugates, again, this is a video which we are not able to play. So antibody, the immunotherapy and other target therapies have always been antibodies, monoclonal antibodies. Now they are kind of attaching a chemotherapy type of a drug and making a combination. Why does this combination help? Because it reduces the toxicity of chemotherapy. It is like you are combining the chemotherapy with an antibody. The antibody takes you to that antigen, which is the tumor, and the chemotherapy is released only into that tumor. So it kind of should technically or theoretically reduce the toxicity of the chemotherapy, but of course it has not been so in clinical practice. So why I've brought up the concept of antibody drug conjugates? They're coming up in almost all cancers, but the enfortumab vedotin, which is very important for us in the first line urothelial cancers, is an antibody drug conjugate, and that's why I had to bring up this topic. Antibody is directed against nectin-4, which is very commonly expressed on the urothelial cancer cells. And the payload is monomethyl auristatin E. That is again a microtubule inhibitor like docetaxel. It has significant hematological, ocular, pulmonary, skin toxicity. I tend to send all of my patients who will start enfortumab for a thorough skin checkup for the dermatologist, because it will be easy for him to follow up if something happens later on, and an ophthalmological checkup. And of course, we tend to kind of do grading of neuropathy prior to start, because again, as I told, all the molecules which inhibit the tubulins or the tubules tend to cause that peripheral neuropathy. And of course, as we discussed, it is a standard of care for first line stage 4 urothelial cancers. And it has also approval of FDA as a single agent after 2 lines. Complete, we are doing a lot of next generation sequencing in all the stage 4 cancers to see if there are any actionable mutations, and using targeted therapies. There is one FGFR gene mutations, which are very common, FGFR 1, 2, 3, all the gene mutations in urothelial cancers. And there is a drug called erdafitinib, which has been US FDA approved recently. Nobody has used it. It's not available in India, but for completion's sake, I've mentioned it. Thank you for now, because this is what it is. These are the updates. Apart from that, in penile cancer and testicular cancer, there's hardly been any newer updates, and the guidelines which are there since the past 25 to 30 years still continue. And if there are any updates, we will definitely discuss it in the coming sessions. Thank you, sir. Over to
Very
you, Chandramohan.
nicely. You have a lot of knowledge and crisp also. The only problem is so many drugs are coming and going, and for us, even in our forums, these are discussed in detail by particularly those specialists who concentrate on uro-oncology. Though we may not give, but we should know these drugs. Generally, we don't administer the chemotherapy drugs. You are the right person, but you have told it. This is actually YouTube link, which will be there forever, so that any PGs for next 2-3 years they can refer it, read, and quickly finish. It's like a YouTube video. So I must thank you, and you are very well updated. You might be treating all the diseases, so you should have a lot of memory with all the chemotherapeutic drugs. What do you say? Lot of chemotherapeutic drugs.
That's true, sir. I think the practice in US has been to subspecialize organ wise. Now, even medical oncologists are not doing head to toe. So they are taking up one or two organs, maybe,
Mhm.
and doing more research in that, seeing more of those cases, and publishing more of their data. And I think that's the way to go forward. But in India, it takes a bit of a time because, as you know, in India, the difference between a surgical oncologist, medical oncologist, and a radiation oncologist is only poorly understood as of now, as much as I
Even
understand.
that is not understood.
Correct. So, subspecialization of a medical oncologist is, I think, too far-sighted
Too
right
far,
now.
but it will happen.
But it will happen eventually. Definitely, it is going to happen,
It's going.
and I think that's the way to go
Younger
because
generation, the next generation, and those who completed more than 20 years, like us, it's okay to comment like this, that younger generation who has just passed or just 5 years past, they should slowly start looking into the subspecialty and research work. The
okay.
main reason is if you constantly do only one work, the outcome will be better, and patients also will search for such outcome patients, such outcome producing doctors. So you are interested in GU, GU,
I'm interested in GU, sir. My interests are basically hematology and GU.
hematology and GU. Very
In
nice.
hematology, I was interested right from my MBBS. Somehow, it is a very
Okay,
thrilling subject for me.
very good. Very nice.
GU specifically when it comes to solid tumors.
Yeah,
Uh,
yeah.
don't ask me why because it's been
Hmm.
it's been. I mean, that's how it has been. I mean, while reading and all, I think the field is very interesting. I mean, you're seeing a lot of new developments as we just discussed,
Yeah, yeah.
and there are many more under trial which are going to get approved in the coming 2 to 3 years. So I think this field is evolving and slowly we're getting better at treating these neoplasms which have been.
Many of the drugs were not there when we were doing MCH 20 years back. Pembrolizumab, so much it has come into the market last 2 years. We are supposed to know. Sunitinib was also like that. Especially bladder cancer, chemotherapy role increased, neoadjuvant, adjuvant, very much. I don't know about kidney cancer. I really doubt neoadjuvant there is no role, but adjuvant also we rarely use it unless it's obvious metastatic disease. Locally advanced disease resectable without margin positive, we are slightly reluctant to give the chemotherapy in kidney. But immunochemotherapy is established anyway for the advanced metastatic disease. But prostate cancer, of course, is a big subject. It's too big a subject. Still, we try to look for our cases like radical prostatectomy, which is confined to this thing. But the combination which you told, ADT plus docetaxel plus so many combinations have come. I hope the patient tolerates well all the medicines. So I think chemotherapy role has increased in genitourinary oncology a lot. Testicular cancer is 100% we need chemotherapy some way or the other way. Penile cancer also, yes, cisplatinum is useful. So almost all cancers we involve this thing. Good that we interacted casually, and then I have given a right person. Though previously I don't know much about you, it is good that you have presented very well. This is a bigger forum, pure urology. Usually we discuss surgical technique-based discussion, but occasionally I will put in, so that people will not get bored because techniques are limited and daily discussing technique is not possible. I am very thank you for that. Srinath,
With your permission, one point I would like to make finally, sir.
please, please.
Regarding the penile cancers, there is a role of neoadjuvant chemotherapy right now.
Yeah.
All penile cancers who present with abdominal nodes, pelvic nodes, have to be given a TIP regimen as a neoadjuvant and then taken up for surgery. That's a standard of care now. Just wanted to put that point through the forum.
Very good. Great. Thank you very much. Excellent. You did very well, more than my expectation. Highly appreciated.
Any questions we're ready to take, sir? I mean,
if there are not money, we will conclude here. People listened, nearly 50 to 100 people have come and joined online, entire world. But by tomorrow, you see the YouTube link. I will share with you a YouTube link that will be there forever.
There's a question in the chat box, sir, which I'll take it.
Yeah, take.
Dr. Ahmed has put why in low risk patients triple therapy. Sir, low risk patients, there is no approval for triple therapy. In the combination of ADT, docetaxel, and darolutamide, it has shown benefit. But even the guidelines say that there is no need. It's an overkill for low risk. So currently, we are only using combination of ADT and darolutamide or abiraterone, but not doing docetaxel in low risk patients. I just want to make that clear.
Yes. Okay. Thank you then, Satish. Srinath.
Thank you, sir.
Okay. Thank you very much.